There are plenty of resources that talk about how to score the Glasgow Coma Scale, what it is, what it's for, but they don't often talk about how you actually do it. So this is a video to break it down for you. This is a scale that assesses a person's level of consciousness. There are three things that a provider assesses to provide a score for the scale. Number one, eye-opening. Number two, verbal response. And number three, motor response. Eye-opening is the ability of a person to open their eyes, whether it's an intentional opening of the eyes and it's already open, or the opening of the eyes is a response to someone saying, "Can you open your eyes for me?" Or the opening of the eyes is a response to someone poking or pinching you. Think about the last one. If someone were to poke or pinch you, if your eyes were closed, of course, in that case, would you think that naturally your eyes would maybe open as a response to wanting to know what the heck just poked or pinched you? We also test for verbal responses. Is this person able to speak in eloquent sentences? Are they saying random words? Are they saying words at all? Are they just mumbling? Are they even able to make auditory or audible noises? Some people are not able to make any noise at all, just depending on the extent of their injury. Last one, motor response. Is this person able to intentionally move their arm or move their leg? Are they able to move at all? If they can move, is it just random movements? If I'm pinching this person on their arm or on their leg, are they able to intentionally move their limb away? Or does me pinching their arm or leg just elicit a random jerking of the knee or a jerking of the elbow? And this is what we're going to go over. The Glasgow Coma Scale can actually be done probably within 30 seconds. It is super, super fast. And I'm going to give you a scenario because I think that's the best way to help people learn. So I want you to imagine that you just went to the ER because your friend, of course, this is just a hypothetical scenario, your friend just got into a motorcycle accident. You enter your room and you see that your friend's eyes are closed. You enter the room and you say, "Hey, it's me, it's Galatea. I heard what happened to you and I'm here for you." As you continue to enter the room, you notice your friend isn't responding. They're not opening their eyes. Now, understand, it's not that you were not loud enough for your friend to hear. It's not that your friend is ignoring you. Understand that this is a situation because your friend's brain is damaged. This person just at this time is not able to open their eyes as a response to a verbal stimulus. However, you want to test, is my friend okay? Can they open their eyes? So what you end up doing is coming closer to them and you say, "Hey, would you mind opening your eyes for me?" And they still don't open their eyes. So what's next? Now what you do is you probably go close to your friend and then you try to give a gentle nudge or you poke them. Now realistically, you do not want to poke them. You want to apply a tactile stimulus, yes, but you want to apply a firm pressure. That way you assure that your friend can actually feel you because pokes can be relatively gentle. Now understand there are three specific places that you can and you should apply pressure. That way we keep it consistent across the board. The first one is at the nail bed of either your finger or your toes. The second one is at the upper trap. And the third one is the supraorbital notch, which is the bone between your eyebrow and your eyeball. So I go over to my friend and I decide to choose the fingernail bed. Now from here, there are a couple things that can happen from my friend. As a response to this firm pressure being applied to my friend's nail bed, they might have a reaction and they might open their eyes. Okay, great, my friend can open their eyes. But another potential might be that they still do not open their eyes. And again, depending on the region or severity of brain damage, that can be a result. I personally like to group eye-opening with motor response together, and that's because they're tested in the same way. So let's talk about the motor response next. So remember, you've gone into the room, you say, "Hey, it's Galatea, I heard what happened, I'm here for you." What you notice, of course, with the eye-opening response, but now we're talking about motor, you notice that your friends didn't open their eyes, but really they just didn't have any reaction at all. Their arms didn't move, their legs didn't move. So you think to yourself, well, can my friend move their body at all? So what you end up doing is you go closer to them and say, "Hey, can you try to shake my hand? Can you try to give me a hug?" to see if they can. A verbal stimulus. But in this case, let's say still no response. So the next thing you're going to do is probably go over there and again, give a gentle nudge. But as we know, we don't want to give a gentle nudge, right? We want to apply firm pressure to one of those three places that I mentioned before. Supraorbital notch, fingernail bed or toenail bed, as well as the upper trap. Once a tactile stimulus is provided, a couple things can happen. The first one is that your friend might go into what's called decerebrate posturing. And this is where a person's reflex to firm pressure results in extended arms as well as extended legs and pronated arms. Another response could be decorticate posturing, where your friend has a reflex, again, response to firm pressure where their arms bend inwards, their hands come toward their chest, and their legs are extended. Both decorticate and decerebrate posturing are not intentional movements. Again, they're reflexes that occur when the brain is damaged. Another potential result from you applying that firm pressure to any of those three places that we talked about is movement that doesn't occur in these patterns. However, at the same time, the movement is not intentional. For example, I squeeze my friend's upper trap and they end up flinching their ankle. All right, it has nothing to do with the upper trap at all. You would think that in general, if you were to squeeze someone's upper trap, that they would maybe move away from that area. But if it's something like the ankle, it is truly just random. Another potential could be that your friend actually does move their shoulder away. So it is a bit more intentional, and this would suggest then less brain damage. The last assessment we make with the Glasgow Coma Scale is with verbal response. Remember, you come into the ER, you say, hey, it's Galatea. I heard what happened. I'm here for you. You see your friend doesn't open their eyes. You see that they don't move. And the last thing is that they don't respond to you. So you go over to them and you say, hey, how are you doing? But they still don't respond. I want to know if my friend can say anything at all. Once you've asked that question, these are your potential responses. Number one, they don't say anything at all. Number two, maybe they make a sound like, so not actual words, just mumbling, just kind of sounds. Number three, they could be saying words, but maybe they just don't really make any sense. So it's like as if they were just saying a bunch of random words together, like chair, tree, potato, reindeer, right? Number four, it could be that your friend can talk. They can make sentences, but half the time it kind of just doesn't make sense. So essentially they seem confused. And then lastly, maybe there is that potential where they actually respond to you appropriately. So really, when you break down what you actually need to do to give a score on the Glasgow Coma Scale, there's only two things that you need to do. And the first one is talk to them. You want to talk to them and ask them to open their eyes. You want to talk to them and ask them to give you a handshake or wiggle their toes, whatever it is. And then you want to talk to them to see if they're able to talk back to you. Well, if the verbal command or the verbal request doesn't work, you end up doing the second option, which is applying firm pressure to supraorbital notch, nail bed, whether it's the finger or the toes, and or the upper trap muscle, whatever is the most appropriate. And all you do is just assess their response to that. So really, it's just two things that you might need to do. And for that reason, it might take even less than 30 seconds to actually grade someone on the Glasgow Coma Scale. I talk to them. If they don't respond, I'm going to apply firm pressure and then just assess what happens. So here's some food for thought. I want to ask you, if your patient or your friend is able to respond verbally, they're able to intentionally move, and they're able to open their eyes on your command, is there a purpose of double dipping and applying firm pressure to their upper trap or their supraorbital notch or their nail bed? I would say no. What is the point of that? You've already been able to grade them at a higher level on the Glasgow Coma Scale. Now, another thing, do you really need to push on their nail bed 3 times to assess the 3 criteria of eye-opening, verbal response, and motor response? No, literally just do it once, and then you're able to see and assess all of those at the same time. I scored 100% on my NPTE. So if you're studying for the NPTE and enjoy the way this was taught, check out our courses at sptwithme.com. Check out the references for more information.